Hi, Jonathan.
Good morning. Good morning. How are you?
I'm well. How are you?
I'm doing well.
It's been a while since we spoke.
I know. How you been?
Good, good. I moved into a new position, so I'm not the executive assistant for Jim anymore. We have Denise now that we hired in that position, and I moved into community development initiative. So I'll be the coordinator for that.
Very nice. Very nice. So
Exciting,
we should
exciting
be
stuff.
we should be talking to you more often,
You will be, yeah.
right? Yeah. Nice. Congratulations.
Thank you.
And I see that Dave is about to connect now.
Mhm.
Good morning, Dave. I think you're still muted there.
Mhm.
Let me unmute. Good to see you.
Likewise, man.
I like your wall art, including the bicycle.
I figure I haven't used it in about a year. Might as well, make it a piece of art.
I know the feeling. Oh, thank you for agreeing to do this, and thank you for actually inspiring this community forum.
No, I think it's a topic that is it's deserving of a conversation. Let's put it that way. And
Yeah,
I think
I think
based on
so.
that initiative from DHS, I mean, it's ambitious, but I think
Yes.
if we do it the right way, I think we can start moving the needle in the right direction.
Yeah, you can start to make a difference. Yeah,
Yeah,
I
absolutely.
agree. I agree. It's really interesting. We have a faculty member from Drexel Medical School who isn't going to be able to join us, but registered so I can send her a copy of the video because
Nice.
she wants to use it for her class.
Good.
So we're already having an impact.
So that means we have to sound very professorial, right?
Exactly. Oh. Yeah, and we're waiting for Julie and Disha.
Indisha, correct.
Yeah. So you're chairing one of these subcommittees as well?
I am. Somehow I ended up being the chair of the Northwest Zone.
That's curious.
Yes.
I mean, you have to travel to Erie or
No, I mean, we're lucky that all the meetings are virtual.
like this,
So,
yeah.
like this, exactly. No, otherwise it would have been quite a task, to do that.
Yeah,
So, I think the pandemic kind of helped me on that end.
yeah. It's had some serious disadvantages, but it's had some advantages as well. And
Yes.
so we've moved all these community forums to online, and candidly, it's increased attendance. And I think they're actually every bit as interesting as when they were in live. We're probably going to go back to being in live at some point, but
Okay. Were you thinking about maybe doing a hybrid as well? Maybe keep doing both?
yeah, we did a survey, and what we got back was do a hybrid,
Yeah.
bring them back real people, but then broadcast it via Zoom. So
Yeah, I think that works because I mean, especially for individuals who are traveling,
yeah,
I mean, literally you could be anywhere and still be able to participate, which I think makes it very interactive.
yeah. We had a school board meeting last night, and one of the board members was driving in South Carolina while we were meeting.
There you go.
It's a very big school district. What can I say?
I'm sure. What else is new on your end?
Oh, a lot of this, with the big other things we're working on are the train stuff, trying to bring the passenger rail service back, and that seems
I
to be
saw
moving
that.
along pretty well. The county has really stepped up and taken a lot of leadership, and it looks like they're going to create a 3-county authority to really launch it. So there's a lot of interest in that.
Because I have heard that the problem, I guess, that the feds had allocated the money, but that the issue was more on the state providing the match for the. Is that true, or?
There's a little bit of an issue with the state where the state would prefer the service, I think, to be run with SEPTA,
Mhm.
because if it's run by Amtrak, they have to provide a match. They have to
I
provide
see.
an operating subsidy. With SEPTA, it's only a voluntary sort of subsidy that they would have to provide. There are pluses and minuses both ways. I mean, SEPTA,
Sure.
is there, but they run the commuter service.
Right.
Amtrak has the ability to foster a negotiation with Norfolk Southern in an easier way. So using the rail lines, which is really an important issue. So But, you know, Amtrak said if the federal infrastructure bill passes, they think they could restore passenger rail service to Reading by 2025, which would be
Oh, nice.
amazing.
That would be great.
Just absolutely amazing. Make
Yeah,
life
that's-
easier for a lot of people.
I know that's the big irony is that Reading Railroad is in the monopoly game, and yet
that's
we don't
it.
have. And that's it. That's the extent of it, right?
Yeah, exactly. Exactly.
Oh
So,
boy.
so that's been interesting to be involved in and exciting to see it happen. And some conversations with the city about what happens with the train when the trains come back. What's it do for the city and how do they plan for that?
Is Schuylkill County still part of that?
No,
vision?
they're not. It
They're
would
not.
stop here in Reading or maybe in Wyomissing.
I see. I see. Wow.
I think ultimately there's some conversation about going further north, but that's not part of it yet.
Interesting. Okay.
It's, you know, it's Berks, Chester, and Montgomery that are having the conversation about the.
Right,
the
right,
authority.
right.
So,
No, I mean, that would definitely open up Reading to Philadelphia. It's sort of like an extended suburbs of Philadelphia,
yeah,
which I think, you know, from an economic development standpoint, that would be a huge.
it would be helpful. Yeah,
Yeah.
exactly.
Mhm.
You know, with the medical school, we have a lot of students coming from Philly to go there. And so the trains are significant for them as well.
Right, right.
I see Disha is joining us.
I believe so. Yeah.
You're muted.
There we go. Good
There we
morning.
go.
Good
Hi,
morning,
how are
Disha.
you?
How are you?
Good. Hi, Jonathan. Hi, Dave. How's it going?
Good.
It's going. It's only Thursday.
Oh, God. I'll be glad when Thursday's over, let me tell
Yeah, still have one more day to go.
you.
Yeah.
We had a school board meeting till 10 o'clock last night.
Oh, my goodness.
Yeah.
So at
Lots of
least I
stuff.
know it's not just my school district that the meetings go on forever. Oh, my
Yeah.
gosh.
Yeah, lots to discuss.
I'm sure.
Yeah. And it's I don't know, it can be discouraging. I
Yes.
think that the last 18 months, I've seen people just treat other people with such disdain. And it almost, you know, in the school board meetings, I'm almost like, are these the people that are raising our kids? Because these are the people that how we're speaking to one another is so disrespectful. And it's like, I just can only imagine the conversation that goes on at home. And I've been just disappointed in adults,
Yeah.
you know, how we respond to people with differing opinions, that we meet no one with grace.
Yeah.
It's really disappointing.
We had a community forum that we scheduled in September on early childhood education. And we had to shut it down right at the beginning of it because some people, they hacked it and they were.
Is that right?
They were sending and saying racist and sexist.
Oh,
things
gosh.
that were just terrible.
Wow.
So it's
Hi,
and it was
Julie.
early
That's
childhood
horrible.
education. You'd have thought that would have been easy.
Yeah.
Yeah, one would think.
Thank you all for being here. In terms of format, what I'm thinking is I'll start, introduce the topic, welcome everybody. If John Weidenhammer is joining us, I'm going to ask him. He's the chairman of the Berks Alliance. I'll ask him to do a welcome on behalf of the Berks Alliance, and then we'll go to the three of you. I'm presuming we'll start, Julie, with you, and we'll give you the ability to move the PowerPoint on the screen. And then Disha, I'll come to you, we'll come to you, and then Jonathan, will let you be the closer. We are going to record this and make it available. We'll make it available to you, but we'll make it available to everybody who registered for the event. I will ask people to use the chat function to submit their comments and questions. I'll collect those and ask those at the end of the session. So we'll have those. If we don't get through them all, I'll send them to the three of you and you guys can respond to that.
Okay.
Question, Julie, on the slides that you sent to Dave, I noticed that there were some corrections in one of the slides. I don't know if you're going to be using an updated deck or.
Yes, which ones?
Let
Do you know
me
which
pull.
ones?
Yeah, let me pull it up. I think it was towards the end. Give me a second here. Yeah, it was 15.
Slide 15.
Yeah,
Oh, I see. Yeah, we.
under potential partners.
Oh, I had to cross that out. Yeah.
Got it. I can fix that.
Yep. Oh, thanks for the catch, Jonathan.
Yep.
Yep, I just crossed that out. So Julie, in terms of who's presenting first, how would you like this to go? Do you want to go through the racks? And then you want me to pick up talking about the local SDOH data from our Reading Hospital project?
Yeah,
And
that
then,
sounds good.
okay.
Good.
And then do you want to pick it back up with the equity zone? Do you want me to do that?
I think if you're comfortable speaking to it, it probably will be more meaningful for the group to hear about it from you.
Okay, so I'll do that. And then Jonathan, you're going to round us out and talk about all of this from a payer perspective and why it's important to have
fine.
a partnership. Okay.
Mhm.
Okay, I'll
All
then
right.
move those slides towards the end that you provided, Jonathan, just to make sure it makes sense.
Good. Julie, do you want to, once you get it done, you want to bring it up just to make sure we can see it?
Yep.
And Dave, from a timing perspective, are you going to give us a hint when we're running out of time, or
Yes.
you want us to stop?
Yes.
Okay.
Yes. You guys should talk as long as you need to talk about the topic, because I think that's what's important. I'll be collecting, as I said, I'll be collecting the questions and I'll raise those with you as we get time. And we will try to have the hard stop at 1 o'clock. But sometimes we don't do that. Hopefully we don't have to shut this one down early. Hopefully this is.
Mm,
It should not be controversial, but you never know.
No. But you wouldn't think early childhood education was that controversial. We can see it, Julie, so that's good.
yeah.
Good.
Perfect.
Okay. Well, we got 5 more minutes. We've got a few people in the waiting room. Any questions or things you want to raise before we get started and start bringing people in?
No, thank you for the opportunity to share with the group.
Sure.
Absolutely.
No, I have to thank you guys. This is really a good topic and an interesting topic and a timely topic.
I think so.
And of course, Dave, I don't know if you also want to kind of highlight the fact that the Berks Alliance already made some investments in 19602.
Yeah.
One of which is the Berks Latino Workforce Development Corporation. So
Right.
this is one of our HEC zones. So I think that there's alignment in terms of what this initiative wants to accomplish, and then some of the work that the Berks Alliance is also doing.
Okay, I was going to give you credit for Tech Central and the work Berks. But yeah, I should emphasize. I'll mention that too.
Yeah, you're definitely a partner there. So yeah.
Yeah. And back to our train conversation, Jonathan. That's the train station is located in one of those zones. So that's.
Oh, nice. Very nice. So say, Julie, we're bringing the train to town, right?
We can only hope. Make it easier for people to get here.
Right.
And as Jonathan said, Reading should have a railroad. The names just fit together.
I think it's a railroaded monopoly, so.
Yeah,
Yes.
we need the alignment with the game. Absolutely.
So if you guys are okay, we'll start letting people in. We have 12 people waiting to get in.
That's fine. Yep.
So we have a couple minutes before we'll start. So we thank you for your patience and your willingness to wait for us to get it started here. Okay, we'll be starting in a couple minutes.
Dave, we should find a way to play music or something during
Yeah, we
these
should.
calls so that when people sign in, they know that they've got a audio connection.
A live event. Yeah, that's good. That's a good idea, John. It certainly can't be me singing though.
Well, it could be you singing. Why not?
No elevator music, please.
Jonathan, is that your cat?
That is my cat, yes.
It looks pretty comfortable.
It's a cat that wants to be a dog.
Have you seen that ad where the guy has the cat that is herding cattle and
I have.
jumps
love
into
that
the
ad.
water and comes out with a stick?
I have. Well, that's my cat. He likes to retrieve things. He likes to fetch things. I have no idea why, but very unique behavior.
Yeah, that's unusual. Often cats will go chase something, but they won't bring it back.
Right.
Yeah, exactly. Okay. We'll wait one more minute and then we'll get started. Okay. I want to thank everybody for joining us this morning and into the afternoon. My name is Dave Myers. I am the director of the Berks Alliance, and we are very pleased to host this community forum, part of our community forum series that we do on the third Thursdays of the month. We think this is a very interesting and timely topic. I'm going to cover some ground rules before we really begin. We would like you to show us your face, but not your voice. So if you would start your video, but mute yourself, that would be great. We ask you to submit your questions and comments through the chat function, and we will collect those and share them with our presenters. Any questions that we do not get to or comments that we do not get to, we'll share with the presenters, have them give them a chance to respond to those, and we'll share those back with everybody. We are recording this program. We put it on the Berks Alliance website, and we will send it out to everybody who is registered for the event. So it's my privilege to introduce John Weidenhammer, who is the chair of the Berks Alliance, for some brief comments, and then we'll come back and introduce our panelists. John?
Hi, Dave. Thanks so much, and good morning, everybody. Thanks for joining our call today. I want to start by thanking our presenters. They put a lot of work into this presentation today, so we appreciate that. I also want to thank Dave for arranging everything and doing such great work behind the scenes. As you may know, the Berks Alliance is a collaboration of anchor institutions in Berks County, and we have a focus on community development. We're particularly concerned about the improving the health, wealth, and education attainment of our community. We're also concerned about making sure that there's an adequate supply of living wage jobs for citizens of Berks County, and that there's an adequate supply of people to fill those jobs. And one of our most important initiatives is providing these community conversations so that we can bring topics to the community that are of particular concern. In fact, if you have ideas about things that you'd like to have us present, we're always open to topics of interest. We really do have a busy plan for the remainder of this year and into next year, but we certainly do want to hear from you about topics of interest. Also, we're going to be starting a spotlight series next week, where we're going to be presenting information about organizations in the community that we think the community should know more about. So thanks again for joining, and I'll turn it back to Dave.
Great. Thank you, John. Today's program is on social determinants of health. It is focusing on the fact that in something like 80% of the healthcare visits are driven by social factors, not genetic factors. And so it's an important thing to understand and consider. We have three presenters, and I will introduce all three of them, and then we'll start with the first presentation. Our first presenter is Julie Evans, and she is the Regional Accountable Healthcare Council Project Manager, and she's also a senior consultant for Crossfire. Julie is currently a project manager for the statewide initiative to improve the health outcomes of Medicaid participants across the state through using social determinant of health and health equity focused initiatives. She's responsible for the development and design of program interventions and strategies for areas of profound health disparity, and we're going to learn a little bit more about that. Prior to joining the company, she served as a program coordinator for a hospital-based smoking cessation program in Auckland, New Zealand. So welcome back to this part of the world. And she holds a BS in behavioral health and a master in health administration from Penn State University. Our second presenter is going to be Deisha Dixon, who is the Associate Vice President of Community Wellness for Reading Health and Tower Health. She is the chair of the Lehigh Capital Region Accountable Health Council, which includes Berks County. At Tower Health, she oversees the development and implementation and management of community benefit programs. She's responsible for leading the community health needs assessment for all the hospitals in the Tower Health system, aligning internal and external stakeholders to address pressing community health needs. She's led the hospital in adding innovative programming to address the social needs of patients, such as medical legal partnership that they've created, community connectivity connection program, and the street medicine program that they run. She co-chairs the Reading Hospital and Tower Health System Diversity and Inclusion Councils. Deisha holds a master's degree in organizational management from Eastern University. And then our third presenter is Jonathan Encarnacion. Jonathan is the Administrative Director for UPMC Healthcare's Medical Assistance Program. He is also the chair of the Berks Latino Development Corporation Board of Directors. And I have to be fair and disclose that the Berks Alliance has helped support the Tech Centro location in the city, and you're going to learn a little bit more about why that's important. And he's a former director of Berks County Centro Hispano Daniel Torres. He's also a member of the State Regional Healthcare Council, Accountable Healthcare Council, and he's on the board of managers of the Wells Fargo Regional Foundation. Jonathan holds a master's degree from Johns Hopkins. And just really quickly, the Regional Accountable Healthcare Program is an initiative of the Pennsylvania Department of Human Services designed to reduce healthcare inequities by addressing the social determinants of health. So, Julie, I'm going to turn it over to you.
I had to find my unmute, I apologize. But thank you all for having us today. It's a pleasure to be here and really speak to what we're doing through the Regional Accountable Health Councils and really how we can start to engage more local voices and resources as we go forward. You know, we've really been in a planning phase for the past several months and really looking forward to getting more into the groundwork within the communities to start to see some change. So we'll go through these slides today. Please, as Dave mentioned, use the chat for any questions, and we'd be happy to address those as we go through. But to give a little bit of background as to why we have these regional accountable health councils, which we call RACs for short. So the Department of Human Services has kind of said, you know, we understand that just focusing on healthcare alone isn't enough to actually address health needs. And so over the past several months and years, they've started to develop what they're considering a roadmap to whole person health care. So how can we start to care for the whole person, considering both their health needs and their social determinant needs, which are really where you live, work, play. How are those, you know, environments impacting your health? Just based on, you know, what street you live on, you can have a different life expectancy than what you may have 3 blocks away. And so thinking about those factors and how they impact our health, the state understood that there was a need for some additional programming to bring in social determinants of health and health equity considerations to our healthcare really process, our healthcare system. And so I have shared a link here to the whole person care report, but really the goal is to create a system that is increasingly designed to meet the holistic needs of each person, instead of trying to force each person to fit their needs into a siloed healthcare system. So I'm sure we all know from experience that our individual journeys through healthcare look very different. You know, we all have our own needs. We all come from a different place. And this is really a model trying to better accommodate that, understanding we aren't all going to fit through the same process. It really needs to be customized to each individual to see the best health outcomes. And so there are 3 interwoven components to this model. One is value. So how can we make high quality, low cost healthcare? The second is equity, making sure that, you know, no matter where you live, what your background is, whether that be race or religion, no matter where you are receiving services, that your healthcare journey is equitable. So everyone should see the same results when they receive care. And that also brings us to social determinants of health, the third piece of this kind of model, where we want to address those social determinants and not just health when thinking about whole person care. And we'll touch on a little bit more on that in a minute here. But to give an idea of how these all play together, this is an image, a little infographic from the report, where you can see how all of these 3 pieces come together through different programs. And the RAC, as seen here, is really focused on the health equity and social determinants of health pieces of this model. And so what we're looking to do is understand that there are communities of what we're calling profound need. So really need beyond the state average in a big way. So a lot of the communities we're seeing are actually performing in the bottom 25% across the state when it comes to health outcomes. So that's what we're calling profound health need. And, you know, babies born in this zip code of profound need may be neighboring a zip code where you have a huge life expectancy difference just based on where you live. And so understanding that, the RACs have been created through medical assistance agreements. So these are our Medicaid programs and the Medicaid managed care organizations that deliver that service, to work with other, you know, behavioral health primary contractors and community based organizations to come together and say, how can we start to understand the interventions that need to be seen through, and how can we actually implement them to see change in these communities and provide the services that would be needed to close the gap between that life expectancy that we're seeing differ between the zip code you may live in. And so this is really something that, you know, as a whole person care model will continue to develop at the state level. But for the purpose of the RAC, we're really focused on that social determinants of health and health equity components. So going ahead to an overview of the RAC. So the RACs provide a community-led approach. So really focusing on the providers in a given area to say, what do we need to do? How do we coordinate activities? And how do we start to focus on, again, the social determinants of health and health equity to actually reduce health disparities? And again, health disparities is really those poor health outcomes that come about in a community based on these social determinants. And so there are 5 RACs across the Commonwealth. They align with the physical health choices zones, if you're familiar with them. If you're not, it's really just the Northwest, Southwest, Lehigh Capital, Northeast, and Southeast is really how we divide up across the state. And so today we'll really focus our discussion around the Lehigh Capital Zone just for the purpose of this group, but there will be available information publicly over the next coming months of the work we're doing across the state. There are 5 key goals of each council. So all the councils are aligned on having 5 goals that, number 1, we are focused on promoting health equity and eliminating health disparities. Number 2, our goal is to identify and mitigate regional social determinant of health needs. So really focusing on that local level, how do we implement change specific for what that community needs? The 3rd is aligning value-based purchasing initiatives to achieve better care and better health at lower costs. Those value-based purchasing initiatives are really focused at the Medicaid managed care level. How can they start to work with community-based organizations to really see through care in a different way than we have traditionally? Number 4 is to support and steer population health improvement processes. So really looking at, how do we improve the health of a community and not just an individual? That's really the foundation of the work we're hoping to achieve. And the 5th point here is the center health improvement efforts in communities where needs exist. So, we can say, let's focus on Berks County and we are going to, implement a new way of healthcare, and that would be great. But the focus of the health equity is to really focus on the areas where the need is greatest and provide that care specific to them to make sure they do have similar health outcomes to others in the area. And so what we've done is, since about February, when the council started to get together, we've been able to align a lot of these program goals that were set out by the Department of Human Services through various work groups that the council has been operating through. And so we've used publicly available data. So this is data you'd all be able to access through DHS as well, to identify what are the areas of that profound need, that where the needs exist most across the Lehigh Capital area. Once we really identified the where, it then became what. So not only have we been able to see, okay, they are performing poorly with health outcomes, but what are those social determinants of health where we also see poor metrics? So how can we start to draw correlations between the 2 pieces to say, this is where our social determinants of health are clearly impacting our health outcomes? And so we went through an analysis using, again, publicly available data to say something like housing can really impact asthma rates and I would say the complexities of a case of asthma. And so those 2 pieces were sometimes connected in our zones to say, we're seeing overcrowding in housing. We're seeing really old housing. We're seeing high rates of asthma and higher emergency room admission. So those things all start to play a role amongst each other. And so that analysis helped us say, where are the connections? We're seeing these poor health outcomes. We're seeing these root causes. How do we know they're related? And so what we started to do is actually look at literature and evidence that shows the connections and also shows what success stories already exist across the nation where we've seen communities have interventions that actually show that the 2 pieces are directly connected and that we can actually do similar things in our communities to make change. And so literature is great. It's a great way to get started, but we understand that each community is also very different. And so local discussions have been kicking off over the past several months to say, okay, we understand all of this is what the data shows, but what makes the most sense for this community? And so when you think about the population makeup, the income of an area, the housing conditions, the accessibility to transportation, those things all start to change what an intervention may look like based on that community's needs. And so over time, we were able to establish regional priorities and create a strategic plan and business case for regional work that we'd like to do and the funding that may be required to do that. So it's definitely something that we're seeing through now to kind of finalize that strategic plan. And next steps will actually be trying to take that plan into action and seeing where we can start to intervene within the community. And so overarching, just to kind of go back to what are social determinants of health, they are conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, quality of life outcomes, and risks. And that's a loaded definition. That's really the essence of who we are, all of those factors. And so the idea is that when we see that social supports for us can improve our health outcomes, that's then something we want to focus on. So there, and a great example is family and community support. They always say, oh, if you have someone who's supporting you through illness, you have a 33% increased chance of survival, or whatever it may be. That there's that direct impact on health outcomes. And so understanding that, we want to make sure that they're being addressed in the healthcare system directly. And so how much does this impact us? And wanted to share this kind of visual to show that currently there's actually evidence that health outcomes are determined as much by non-health related factors, if not more, than they are by healthcare and health behaviors. So you can see on the left-hand side of this chart, they now say as much as 80% of health outcomes are driven by non-health related factors, while as low as 20% is actually affected by your healthcare service and health providers, health behaviors. And so that's a key consideration. 80-20 is a drastic. It could be as low as 50-50, but that impact, it hasn't been a key consideration for some in their work for an extended period of time. I think Disha and her organization are a great example of those who have been over time including this in their work to see the change that needs to be seen to achieve better health outcomes for patients. And so let me just see here. I think we'll come back to this one, but I think, yeah, this is a slide for later. I should have moved that one down, but I'll actually pass it off to Disha to kind of jump in a little more to what her organization is doing.
Thanks, Julie. There should be a different slide. This was the second one. There should be one that describes the workflow. There it is. Yeah, I'll start there. All right, thanks everyone. Thanks to Dave for inviting us to talk about this. I'm really excited to be with you this afternoon to talk about the work that the RAC has been doing. This is an exciting project because we see the intersection of trying to improve the health and well-being of our most vulnerable neighbors, but for the first time, a big highlight on how their health is severely impacted by social determinants of health. And so it's great to see clinical and community partners together working on this, identifying those health equity zones and really putting forth robust interventions to resolve that. And if that RAC, if it sounds familiar for those of you on the phone that participate in the Community Connection Project, it's because it is very familiar. We started this similar model with CMS about 4 years ago now. We received a $4.5 million grant to implement SDOH screens into our regular workflow. And so we've been testing out the theory that by resolving social determinants of health for Medicaid and Medicare patients, you will ultimately see a reduction in overall healthcare spend and an improvement in their overall health. And so what I have here is just a basic workflow. We have many different workflows, but this is the most basic one. We screen Medicaid and Medicare beneficiaries as they come into our organization for care. We use a CMS provided SUH screen, and we screen for housing, transportation, utilities, personal violence, and food insecurity. As patients are screened, again, as they're waiting for care or 5 days after a visit, we stratify them into 2 categories. If they have needs that we've identified, we provide them a referral summary. So we're able to give them information right there to close their need. If they've been in our emergency department 2 or more times in the last year, we categorize them as being high risk, meaning these patients, because of their needs and their ED usage, they are at a greater risk of unnecessary visits to the emergency department brought on by their unmet needs. And so we put them in a 1-year navigation program, and they are tracked by our community navigators over the next year to make sure that their needs are indeed met at that immediate time, and then to keep checking back in with them to make sure they don't have any additional emerging needs. We work very closely with our community-based organizations. We use a system called Healthify, where we can provide a closed loop referral, meaning the referral starts on our end in the hospital. It's sent out to the community-based organization. They can read the referral from that system, and then they can also let us know from that system, did that patient get the services that they were looking for? So we can close the loop on that, and we're not wondering at the hospital, was our patient able to receive food or the housing assistance that they needed? And so that has been incredibly successful over the last 4 years. Our model here in Berks County has been highlighted in multiple publications, national publications. Just recently, the Heinz Endowment did a report on systems like ours and included us in their report out as a best practice. So if you want to move to the next slide, Julie. So just on the left here, our program, not only was it helpful in being able to address social determinants of health, but one of the greatest parts, in my opinion, was that we were really able to reach out to our community and strengthen our partnerships. We were able to do so many things because of our community-based organizations. We're able to meet and close those needs. And so I can never talk about this program without giving a huge shout out to those community-based organizations who always come to the table and help our patients at their greatest time of need. And these are just some of the organizations that we work with. So over the past 4 years, we've been able to complete over 100,000 screens. And we do screen patients every time we see them if we can, because needs change, as you all know. So that represents a unique patients of about 50,000. We started screening in September of 2018. And so back to how our community-based organizations really help with this program. If you see that last bullet point, 62% of our needs are closed. That is really a testament to our community-based organizations. At Reading Hospital, we don't close the needs, we identify them. So those organizations that are committed to reaching out to our patients, meeting with them, making sure that their needs are met. And that resolution percentage is very, very high. And we're able to track that using our robust data system, Healthify, and the closed loop referral system. You can go to the next slide, Julie. So back to what Julie was saying, using all this data, so our county level community connection project data, and then also the data that's supplied to us through DHS, we're looking at how do we select our health equity zones. And then it was a very robust process, because you can look at many communities across our RAC and say, well, they all at some point would need some type of intervention. But we wanted to make sure that we were really focusing on our most vulnerable community members. And so the first thing that we wanted to do was look at zip codes that were at the bottom 25% of Medicaid outcomes. So essentially the community members who were the least healthy. And so then we moved on to the population. So we wanted to look at where we had enough Medicaid population members to make, a difference. Then we intersected that with social determinants of health. So where is there a correlation between unhealthy members and social determinants of health? And when we overlaid all of that data, we came up with health equity zones where we thought we can make the most impact. Go to the next slide. And so for Berks County, and this really should be no surprise to all of us on the phone here, the health equity zones that we identified was 601 and 602. And we can look at many data sources to justify this. So we looked at poor health outcomes, like I talked about. We looked at inequities because we certainly want to ensure that we are addressing not just social determinants of health and not just health outcomes. We want to make sure that health equity is woven into all of this. Obesity and poor mental health, so we looked at those rates. We looked at high rates of unemployment, poverty, transportation, and the percent of gross income spent or net income spent on rent. And all of these things play into an individual's ability to really put a focus on their health. And as you can see here in this chart, we talked a little bit about life expectancy. And when we look at our state data, our county data, and then our health equity zone, you can see there clearly that there is a need for a focus, particularly if you look at persons below poverty. In those zones, it's 3 times the rate that it is in the county and in the state. And so we looked at many different types of interventions. And I think Julie will agree, these conversations took us a long time just because we wanted to be very intentional about what the intervention would be. And we want to make sure that the intervention that we select is going to be one that will result in some type of longstanding impact. And not to say that this won't change, it won't take different forms. This is a working document. We will revisit this and probably make changes in the future. But one of the interventions that we landed on was transportation, understanding that transportation is very important to get to work, to get to appointments, to get back and forth to your provider. And we wanted to make sure that we had some type of intervention that worked on medical and non-medical needs for transportation. So you can see here, we looked at all of our different partners that we could work with to implement this, this intervention. Again, the format or the blueprint of this started in the RACs, but it really will have to be a community-led initiative. And so we will be reaching out to all of our partners to come to the table to offer your expertise as we try to implement this intervention. And so I think, Jonathan, this is where you will take over.
Yes. Yeah, we can start there, Julie. That's fine. So thank you, Disha, and good afternoon, everyone. I think it's already noontime, but let me start first of all by thanking Julie and Disha for their work. I do chair the Northwest RAC, and so I'm very familiar with the amount of work that's involved in chairing Lehigh Capital. So thank you again for the work that you have done, and Julie, especially you, for facilitating not only Lehigh Capital, but facilitating all 5 zones and the work that we're doing in Berks County. As you can see from this slide, in some cases, again, I mean, I know that to an extent we're preaching to the choir here, but you can see that in some cases, in some areas, the delta, the difference between sometimes different blocks within the same neighborhood, it could be up to 20 years of life in terms of expectancy. And so to a certain extent, I think we're looking at some racial, social issues that we need to address. And again, in the case of Reading, as you already know, the population now, based on the new data that we get from the census, is about 65% Latino and increasing, every single day. So again, we have to make sure that we're paying attention to those health disparities that exist within Latino and communities of color. Obviously, when we look at the business case for addressing social determinants of health, I think it's pretty obvious. We're looking probably in excess of $300 billion in losses to the economy. And just to put this in perspective, if you were to look at the pre-diabetic population as an example, if that pre-diabetic population turns into type 2 diabetes, you're looking at over $1 trillion impact to the economy. So again, there's a strong business case, I think, that can be made to make sure that we're addressing social determinants of health. Julie, next slide. And this one, the only point that I want to make here, if you go all the way down to the bottom and you look at the deaths attributed to, for example, to lung cancer, and then you look above that, you can see that, addressing social determinants of health would actually even have more impact to an extent than the deaths that are attributed to some health-related death, right? In the case of low education, you're looking at 245,000. Racial segregation, which many times we don't think about it, but you're looking at in excess, again, 175,000. Low social support, and again, we're looking at the network of support that low-income families have, over 162,000. And that individual level of poverty, 133,000. Again, making the point here that when we look at those social factors and how they attribute to early death within communities of colors, I think it's quite impactful in our communities. And Julie, I don't know if we have a next slide. Yeah, I think that might be it. I think this might be one of yours, but I just want to make a couple of points here that in the case of, again, I want to give you a perspective from a payer, which in this case, UPMC for You, which is the Medicaid product of UPMC Health Plan. We are very interested, obviously, in addressing social determinants of health for, again, obvious reasons from our end. When you look at our business model basically is based on a healthy member. So that everything that we do is kind of like centered on making sure that that member is healthy. Why? Because at the end of the day, it's the best thing that we can do, and it's the best thing for the member, obviously, to be healthy. But at the end of the day, also the plan and the state and the stakeholders would benefit from having a healthy community. One of the things that UPMC has done, just to give you an idea historically, and this is pre-RAC, and some of the things that we have done to address the social determinants of health, as an example, is investing in issues like housing. In the case of Berks County, a couple of years ago, and I know that Tim Daly is actually listening to this conversation, we invested in Habitat for Humanities and his project, again, to make sure that we are advancing and that we are addressing access to low-income housing in Reading and Berks County. In the case of the work that we have done in Western Pennsylvania, just to give you an idea, we actually invested over $7 million, also providing housing for the homeless population. We actually did that as a pilot program. We actually were able to collect data, and we were able to show that by investing in housing, we actually reduce health costs by a factor of about 35%. So again, the business model is very clear that when we invest in social determinants of health, there is a clear return in investment on the back end, because we are reducing the cost of healthcare, not only for the individual, but also for the community at large. Other projects that I just want to highlight here in Berks County have been investment that we have done with Safe Berks, as an example. And in the case of Surf Berks, where the idea was to connect the victims of domestic violence with providers and enhancing the level of communication between the survivor of domestic violence with those providers to make sure that we were addressing the trauma, obviously, that is involved with those individuals. Very often, we don't tend to think about health in a very holistic way, and I think Julie already alluded to that we have to look at the entire picture. And so even though from the payer's perspective, from UPMC for You, we're only looking at physical health, we also have to think about behavioral health and mental health, and how the two domains kind of connect to each other, and how one domain may impact not only financially, but also behaviorally impact the other. So again, just want to make sure that we are paying attention not only to what's involved within the physical health domain, but also what's involved in the mental health and behavioral health side. The other 2 points that I wanted to connect have to do with, again, Julie at the beginning talked about value-based purchasing opportunities. For the first time in the history of managed care, the managed care industry, we now are able, and when I say we, I'm talking about MCOs, are able to actually get into contractual relationships with community-based organization to begin to address the social determinants of health, right? So organizations, for instance, like Habitat for Humanity is an example, or organizations that may be providing workforce development, employment and training opportunities, we can then contract with them. And in the case, again, of UPMC, we have decided that the first two areas of investment probably most likely was going to be on employment and training, transportation, and then the third one probably would be housing. But again, I mean, I think the overall point that I want to make here is that, you know, there are very much a lot of opportunities right now to be able to connect the work that historically managed care organizations have been doing in this domain with the work that community-based organizations also have been doing. And Jolie, I don't know if maybe this will be also a good segue, briefly, if we can, high level, if you can actually also talk about the direction that DHS is moving towards implementing an electronic platform to be able to then refer our members to those social service organizations that are providing services addressing social determinants of health.
Yeah, I can certainly speak to it at an overview level. I'm not directly working on this project, but really closely related to what we're doing for the regional accountable health councils and our focus on improved collaboration around activities at the community level. DHS is also interested in implementing a program called RISE PA. And the intention of this intervention is really to make an electronic way for different organizations to send referrals to each other and actually track those referrals. So very similar to what Disha and her team are doing, but at a statewide level. So showing success from a model similar to that of Disha's team, we can understand that the value in something like that is great. So looking forward to hearing more from DHS on that, but really their intent is to find opportunities where a single vendor will connect our hospitals and our providers and our community-based organizations and really have that opportunity to seamlessly deliver care, not only in healthcare, but through our community and community-based services and our social needs as well. So that's more to come on that, hopefully over the next several months as they continue to develop that plan. It had initially started off with a vendor selected and some plans that had kicked off, and then it was put on hold. So they're just getting revamped again now to make sure that that can come to be. And their aim is to have that ready to go in about, they say first quarter of 2022 is their aim. So hopefully we'll see something early next year, or not next year, but the following year. I'm already thinking like we're in 2022, sorry, in 2023 is when they hope to see that come to be. So hopefully we will be able to share that information over the coming months as well. And just to kind of share something briefly while I have my screen with the group, I did want to share this tool that's available publicly to all of you. This is what we've used a lot in our council work to understand where the greatest needs are in our communities and across the state. And so I did just want to share this. I'll add the link in the chat for anyone who's interested in playing around with this tool, and I apologize, I know it probably looks kind of small. I can try and zoom in a bit here, but really what this tool does is it gives you insight across the state about performance for various measures and needs. And one that we've really been looking at, or two, I should say, are population health and our social determinants tabs. These really break down our communities of need, and you can actually use the tool down here to filter. So you can actually filter to just look at Berks County, and then you can go and look at what measures are you interested in. So if you are interested in that life expectancy and how, you know, a certain community may compare to another, you can see that here. If you specifically work in, you know, food or with diabetics, there are diabetic measures here and so on. So this is all publicly available, and you can go on and just use it through your browser. You can also download it. I have it saved on my computer now through Tableau Reader. So it's much friendlier using it in that form, just because it can be a little slow online sometimes. So if you have that tool, I highly recommend it. And this social determinants one has some really unique measures that again, play a huge role on our environment and on our health, and really show, employment rate, reading proficiency, environmental factors, home ownership or vacancy rates. And then there's also this SDOH index, which is kind of a combined score of how this area may perform compared to others when it comes to social determinants. So really great tool that's available that DHS has created. And the intent, it came out perfect timing to align with the RAC efforts, and really something that we hope can support other organizations in their work. And if you are wondering where to focus some of your efforts, or funding or whatever it may be for the future of the community, this is a really great tool to learn about the area generally and the state as an entirety. And so looking ahead, we really understand that our interventions that we do move ahead with are going to be dependent on a few different factors. And we've had several discussions across the state level and our local levels. And there were 4 key themes of, if we don't do this, our interventions just won't be successful. And almost all the interventions we hear about across that currently exist across the state is that they're missing one of these factors to really have that amazing impact that it can, whether that be education. So do providers and community-based organizations actually know what resources exist in their community and who to call if they're meeting with someone who needs a support outside of their scope? So do we have the education as supports to our community to actually know where and when to support them and where to send them for that need? And so that's a big piece. The second piece is outreach, making sure we're visible to the community. Do they know we're available? Do they know where to go themselves? And creating that autonomy so that when they do identify a need, they actually know where to go. And because they've seen us in their community, they trust us and know that if that's something they're experiencing, that's a resource that they can reach out to. The third point, which I think is really what the RAC has been successful with so far, is integration, really bringing the different voices of the region together to say, this is what we can do and this is what you can do. If we do that together, we're going to have a much greater impact than we would if we did those activities on our own. And so the opportunity really to make those connections, integrate our work, and seamlessly offer referrals and care and engage across organizations, we'll see that amplified effect within the community. And then the 4th pillar is really access. A lot of people think about access as, do I have a way to get there? And yes, transportation is very important and something that we're seeing as an issue. But in this case, we're talking about, do I have equitable care? So if I am going into a doctor's office, am I going to receive the same care as the person who was in there before me? Or is it going to look different based on whether it's race, religion, or where I'm receiving care? How do we make sure there's equitable care and culturally competent care? So if I am a Spanish speaking individual and that's my first language, how can we make sure that I have the same experience as someone who has English as their first language? How do we provide those services and those competencies to make sure there is equitable care in our communities? And so these 4 pillars are really driving our interventions as we start to think through what we want to do. Each of these pieces will be naturally built into our activities to make sure that we are addressing these needs with any activities we plan to move ahead with. And so there are opportunities to get involved, and you all being from Berks and understanding that we're likely to move ahead with work in the Reading community, we did want to let you know how you can get involved. And so one way is to join a work group within the council. So whether that be joining our meetings that are the larger council meetings where we provide updates, those are public and everyone is welcome. If you want to join a working group where you can join us in discussions about the Reading community specifically and their interventions, that's available. And then if you're part of an organization that has reached beyond Berks County and maybe at a larger state level, we also have opportunities for joining from a governance and sustainability or program integration perspective, where you can really say, this is what's happening at the state level, or this is shown really successful elsewhere, or this is, opportunity as we move forward, how to better the program to serve the needs of the state. And so those are all opportunities that I'd be happy to discuss further with any of you if that is of interest. You can also just be added to our distribution list. So we do send out newsletters. We'd aim for monthly to keep everyone in the know of what we're doing, what's going on, any upcoming public meetings or forums. And we also use that as a way to provide general updates. So if you do just want to, keep track of what we're doing and jump in when you feel like the newsletter speaks to what you do at your organization, that's appropriate as well. The third point here, so we do have a consumer feedback form that we're trying to improve engagement on. So a lot of our work right now has been at a provider level, people who serve the community, which is wonderful, but we really want to increase the voice of our community in the work we plan to do. And so a lot of our work up till now is, data driven and based on what we see in our communities, but we want to hear from the lived community as well. And this form is a great way to provide quick feedback. And we also can have the opportunity to share materials that would actually help you facilitate an in-person session if that would be of interest as well. And these are really ways to collect feedback from the community so we can reflect their points and discussions in our methods of implementation as well as the interventions themselves. And lastly, we love to share success stories and lessons learned amongst ourselves of what we've seen in communities work well, what we've seen fail. And so always happy to hear from others around, previous work that's shown great success, especially in the Berks County area. Anything that you've tried and, this sounded great, but this is why it didn't work. And this is what we did instead. We love to hear those things. We know this work has been going on for a long time. The RAC is a collaborative way to do this work, but it's not new work that's being done. And so understanding that we have a lot to learn from those who've been doing this work for a long time is something we want to make sure helps us get a few steps ahead of the game. So we also have this expression of interest form, and I've listed my email here as well. If you would like to fill out the form or contact me directly, I'm happy to answer any questions about involvement or share any of the links that may be of interest to you to get you involved. And I think that leads us into our questions.
Okay. Well, thank you, panelists. That was a very interesting, very stimulating conversation. We had a number of questions and I've invented a couple myself, so we'll move to those right now. One of the questions was, why was this project focused pretty much exclusively on Medicaid and Medicaid recipients?
Sure.
Are you talking about the RAC or the Community Connection
RAC.
Project? The RAC.
The RAC.
Okay, go ahead, Julie.
Yeah, so because the Medicaid population, number one, is identified as a vulnerable population, we do see that these individuals are eligible for the Medicaid benefit because of their income and their position in Pennsylvania as it relates to poverty. It makes them eligible. So understanding that this population is already of need, that led to understanding that this population also required the interventions. Understanding that this is also initiated by the state, they ultimately are responsible for the healthcare outcomes of those members in the state. So that's really what led to the Medicaid focus. But I will say with these interventions, although we're tracking Medicaid impact, we aren't going to be able to say, oh, we'd like to start this intervention focused on improving food distribution in the community. That's not actually going to only impact Medicaid members. It's going to be something that will have a larger impact. So although we're driving our decisions with Medicaid data and our Medicaid providers, we do expect that the impact will go beyond that population.
And what I would add to that, Julie and Dave, is that when you look at the cost drivers and you look at where the biggest health inequities that exist is in the Medicaid population.
Mm-hmm.
So from an impact standpoint, right, if we start working with this population, this is where we think we can have the biggest impact in our community. And if you look at places like Reading as an example, not too long ago, Reading was the poorest city per capita in the nation, right? So you have a high concentration of low-income families. By the way, Berks County has the biggest population of Medicaid recipients in the Lehigh Capital Zone. So clearly, I think that Berks County and Reading, it's a place where I think something like this could have a tremendous impact.
Okay, good. Thank you.
Also, Dave, I just want to
Sure.
add to that, that in our health equity zone conversation, we talked a lot about people who were uninsured that didn't make it into that conversation because we understood that they would have the same issues as people who are covered under Medicaid, but we had no benchmark data. And so we would just be making assumptions. And so for this to work, we needed to be able to benchmark the data, and we just didn't have any for those that are uninsured. But I did want everyone to know we did take that into account, and we talked about that at length.
Yeah, I was thinking that because DHS is sort of the lead of this, and they are the Medicaid agency for Pennsylvania, that it was easier to access their information. But Jonathan, I think your points are well taken, Julie, yours as well. There was a question about why the focus seems to be so strongly on adults and not so much on children. And I know that the Medicaid program covers probably half of the childbirths in the Commonwealth of Pennsylvania. So is there any reason for that? Is there a separate sort of emphasis going to be on children, or did they just not show up as a problem?
Julie, do you want to take that, or you want me to address that?
Either way, we can both, you can go first and I can follow up.
Sure. In the case, I think we're doing both, Dave. If we look at the demographic, for example, for UPMC4U, about half of our members are children. So we actually will be addressing both populations, not just adults.
Yeah, just to add to that, some of our analysis was focused on adult data because that's what covers the larger portion of the state. And so that data was a driver for us, but all of our social determinant of health data was actually, taking into account the population in its entirety. So although some of our Medicaid outcomes that were driving our decision-making around what kinds of health issues to try and impact, our social determinant of health work is really population focused in its entirety. And our interventions, we have had a few discussions through our groups of how our interventions will vary based on whether we are looking at adults or children. For example, food distribution. There are a lot of great backpack programs across the state where we are giving out food to children while they're at school. And then we have other programs, through food banks that are focused on getting the food directly to mom and dad or whoever it may be in the family. And so that's been a really key point of conversation as we go ahead with these interventions and identify key partners that can really help us be successful. They will vary based on the populations we're trying to reach. And so that's been something that's been highlighted.
Okay. I think that's going to be very, very, very helpful. I know that there had been some concerns early on about low birth weights and teen pregnancies in the city. And so that is going to be interesting to see how that plays out. Interesting, the focus on transportation and a couple of things that I wanted to mention there. When we created when the first branch of the Berks Community Health Center was created, transportation was one of the driving issues. We had parents that were pulling all their kids out of school to take one child who was sick to the emergency room at the hospital and having to walk to get there. And the Berks Alliance had a conversation earlier on with employers about the lack of adequate transportation to get people to work. We know that there are employers that are transporting employees 40, 50, 60 miles to get them to work because they don't have personal transportation. What kinds of strategies do you think are going to emerge from this about getting people access to transportation for healthcare purposes?
So it will definitely vary, but I will first mention that a key point around transportation interventions that we've discussed is, number one, where can we remove transportation as a barrier completely? So in the instance of healthcare, how can we bring healthcare into the community where our members already are? But in the case of, things like grocery store visits or employment, how can we improve transportation for non-medical needs? Because traditionally, healthcare has really been focused on how do we get you to the doctor? And so understanding now the role of social determinants of health, how do we go beyond that medical piece? I don't know that we have a perfect answer yet, but thinking about things like rideshare services, where do we use models similar to what a lot of our FQHCs, our federally qualified health centers across the state have, where they actually have transportation offered to bring you in, or MATP, and continuing to use that program that's available for Medicaid members across the state. But again, a lot of that's health focused. So that non-medical needs is where we're starting to see, there are organizations that offer those services, but how do we improve outreach and education of their availability? And where can we intervene further?
Yeah, there is an organization called Commuter Services of Pennsylvania that works in the same region that we're talking about here in terms of trying to help employers get people to work, and that could be helpful as that. One of the transportation's significant, and it's an access point, but one of the things that COVID has done is shown how important internet access is. All the school districts went to remote learning. They had problems with getting computers to their students. They had problems getting broadband access. How does internet access and telemedicine fit into this equation?
Yeah, so that's definitely another intervention that we looked at. I mean, I think as we were looking at our health equity zones and really tying their health outcomes to their social determinants of health, the digital divide certainly comes up. I think that the thing to keep in mind is that the intervention that we start with, the transportation, that's just one, it's the pilot. So we know there are many things that are, many interventions that we could put forth to help the population. We didn't want to develop all of them at the same time, right? So we wanted to pick one and see how that worked, and then kind of roll the rest of them out. But certainly addressing technology is on the purview as one of the next interventions. And I think there are many people that we can invite to the table to have a more robust conversation about telemedicine. And particularly, I don't know if it was you, Jonathan, or you, Dave, who mentioned that the pandemic is so many healthcare providers moved to telemedicine. And it was great for people like you or I, but not so great for those who live in that zip code, as they don't have the capacity, the bandwidth and their technology to really take advantage of those services. So that's definitely something that we need to focus on. As Julie was talking about transportation, not all of it is going to be physical transportation, getting patients to appointments. Some of it will need to be, how do we take the care to them so that transportation is not an issue at all?
Yeah, David, as Disha mentioned, one of the positive byproducts of the pandemic is the adoption of telemedicine, both from a regulatory perspective and also consumer use. But just to give you an idea, one of the things that we're doing at UPMC is that we're actually providing a free telephone to our Medicaid population. That includes a data plan. And for the most part, I mean, that has been very successful. It's not been widely accepted yet, because there's still a big chunk of the population is not even aware of that. So there's some education that we have to do within the population. But if that individual doesn't have access to the broadband, at least through a cell phone, we're able to bridge that gap and be able to make sure that they have access to telemedicine.
Sort of a question that's connected to the thing about children, but also I think, Disha, you in particular mentioned stuff about behavioral health. One of the things that the COVID epidemic has led to, I think, is an increased need for looking at the challenges of social and emotional things, particularly in children. They were not getting the access to each other in school. There were lots of tensions and things like that. How are you considering adding that aspect to some of the things that you're going to be focusing on? Does that make any sense?
Yeah, so I think that goes back to Julie's slide about putting services into the community, understanding that there are barriers to those services. And I think that's something that as a community, we kind of have to wrap our arms around. What are the barriers to the behavioral health treatments? And some of it could be language, not having enough providers who speak someone's native tongue. Some of it could be time of day, so we're not missing school or work multiple days to seek treatment. So really having to be creative and innovative about how we deliver that type of service. But I think the foundation of the RAC is really to bring all these people to the table to come up with different and more creative and innovative ways to address these issues. And so again, not every issue will be addressed in the rollout of the intervention. It will certainly come as the RACs kind of get their sea legs and figure out what works and who needs to be at the table. And really more importantly, what didn't work. What I will say to those who are listening, we need the help and the feedback of the community and of the members that we're trying to impact. The more feedback that we have from the community and those of you that represent the target population, the better our interventions will be.
And I have to tell you, David, that from a payer perspective, DHS actually is pushing pretty hard right now, and I think it's working in making sure that the physical health payers are talking to the behavioral health payers, and that there's some level of coordination between the two. Because again, you gotta look at the whole individual, not just one side of the equation.
Yeah, no, I understand. I think one of the challenges is when Pennsylvania moved to this type of care, it separated behavioral health from physical health. And I think that was candidly a serious mistake. Both of the health systems in Berks County have had an emphasis on food access, and both of them have had an interest in street medicine. How do they fit into this equation?
So the intention with a lot of our interventions is actually to capitalize on programs just like that, where we get to amplify what they're already doing. So how can we help them improve based on, again, those 4 pillars? So integration, having others engaged so that there's a referral community that exists to address various needs. How can we improve access? So make sure that it's the care they're providing is culturally competent and equitable. And where can we really educate and do outreach to bring together the different activities that already are happening? So as I kind of mentioned before, I think we all know a lot of this work is already going on and has been for some time. And our role isn't to reinvent the wheel. It's really to bring together the various resources that already exist to collaborate and work together. And to kind of touch on the last question as well, we've identified, one of the best parts about the RAC is not only the potential of interventions, but actually that shared learning that kind of can come to be with the different people who come to the table. So knowing that, we have that shared learning opportunity, we've hosted shared learning forums as well. One specifically was focused on behavioral health, and it was a great conversation around, what are the barriers right now? What are some potential solutions? We start brainstorming and have that really forum to begin to at least discuss what is needed and what change needs to be made. We might not always have the solutions right away, but at least it gets us all working towards the same goals. And I think that collaborative piece is really impactful, in addition to the interventions that we hope to see through.
There was some emphasis on housing and the housing issues. The city, and particularly the neighborhoods that you're focusing on, have significantly older housing. Many of them have lead paint problems, and the city is getting some significant funding to address the lead paint issue. Some of the housing stock there's a significant amount of blight. The city's now talking about doing a land bank. What kinds of initiatives are you thinking about in terms of addressing the housing situation, and how do they fit into some of those other efforts that are going on?
I think, David, that the lead issue, especially with children, that's huge, and that's been around for many years. I know that UPMC has been having some conversations recently with Habitat for Humanities to see whether or not an entity, a community-based organization like Habitat could become a provider to do lead remediation work, on behalf of the payer, or working in tandem with the payer. But certainly, I think that's something that needs to be addressed. On the housing side, as I mentioned before, we already have invested some tax credit dollars on the Buttonwood project, but I think we need to do more. I think we need to do more, especially on the addressing the homelessness problem that we have in Berks County. And when you look at the problem per capita, and you benchmark that against, let's say, Philadelphia, even Pittsburgh, it's up there. So that's something that we need to pay attention, and that's something that I think we need to come together and making sure that we make the right investments to address that problem.
Yeah, we did a community forum with the Federal Reserve Bank, and I think one of the gut punches that we got during that conversation was it was focusing on small home improvement loans. And the approval rates in Berks County were terrible. And the approval rates in the neighborhoods that we're talking about were even worse than the rest of Berks County. So even just the ability to fix your stove or fix the leak in your roof is a challenge for many people here in Berks County.
Yeah, and something we've, sorry,
Go
just to
ahead,
add to
go
that,
ahead.
something
Go.
we've talked about a lot as well is how do we support individuals who are renting? You know, you don't always own a home, and we see a large portion of our population is actually renting, and the care of the property should often falls to a landlord who may be negligent. And so that's been another discussion. We've had some really interesting feedback from some, you know, legal aid sources, especially specifically who focus on housing and how they, you know, have been so focused on supporting evictions over the past several, you know, year and a half. I was going to say months. We're well beyond months now, but, you know, supporting individuals who are in that position, that everything else is really falling to the wayside. And that includes, you know, ensuring livable conditions within rental properties and supporting tenants and understanding their rights and what they are entitled to through a lease agreement and things like that, that really do put a lot of, I would say, weight on an individual that causes stress and distress and just, you know, overall impacts mental health and well-being, and is really a key consideration. So thinking about not only our homeowners and the difficulty and access to a loan to make small home improvements, but in addition to our tenants and how can we support them, as that makes up a large portion of the population we're looking at.
This wasn't really raised, but other than Disha in your biography, but what is the medical legal partnership and how does that fit into this whole conversation?
That's a really good question. So that program, several, maybe 30, 40 hospitals across the country have this program, and it's really looking at civil legal issues that can impact someone's health. So for example, our program at Reading, we have an attorney, and through our SDOH screening, we ask questions regarding their housing, and sometimes that needs to be escalated to our attorney. And here's a good example. Habitability is probably one of the biggest referrals that she gets. Her name is Molly Sanders, our attorney. And we get a lot of patients who say, yes, my landlord is negligent in fixing things, the heat, not providing appliances, there's mold, there's sewage, and I'm contacting the landlord and I'm not hearing anything back. And so Molly will, one, reach out to the patient and do an intake, very similar if you were to go to legal aid, and then she'll advocate on behalf of that patient. And in most cases, it doesn't turn into litigation. Most of the time, a landlord receiving a letter from an attorney, they will turn some things around. And so we've had a lot of success with our patients to get these civil legal issues resolved so that they don't end up in homes that are inhabitable. This service is completely free. Patients are never charged. They come through our Community Connection program and referred to MLP that way.
Jonathan, you mentioned value-based purchasing. What does that mean?
So value-based purchasing means we're good with acronyms, right? And legalese with in the healthcare industry, right. But I think in essence, what that means is that we're willing to get into a contractual relationship with a nonprofit entity or with a provider for that matter, which we already do, but that we want to pay for value. We want to pay for results, right? It's not a program-funded initiative. It's an arrangement in which we want to make sure that we're paying for results, that we're paying for impactful change in the community. And in this change, like I say, it has worked with providers, and the providers sometimes, when they're successful in making sure that the patient remains healthy, we incentivize the provider by giving them additional dollars. So we're taking the same approach, and we are applying it now to the nonprofit sector and say, hey, if you're, again, using Habitat as an example, if you're Habitat and we want to contract with you to provide, as an example, home remediation services, we're going to pay you for the success that you have in making sure that our members will have access to, a good home and a good habitable environment, as Tisha was mentioning. So all that to say that for the first time, and again, this is new in our 2021 contract, for the first time, managed care organizations are able to get into contractual relationship with a nonprofit entity to address social determinants of health.
Julie, or Disha or Jonathan, do you have any sort of closing comments you want to make? And then I'm going to ask you to do one more favor before we get to the end here. But is there anything else that you want to talk about?
Actually, I wanted to mention that I think that there's also a major role that the Berks Alliance, I think, can play with respect to social determinants of health. In that, when you look at things like food deserts, as an example, that really correlates very nicely with economic development. Or when you look at, again, access to recreational facilities, which I think speaks to some of the emotional stuff that we talked about before, that also relates to, economic development. When we talked about transportation, and earlier, David, we're talking about, bringing the train to Reading, which I hope that's going to be a reality someday. That's a huge one. That also speaks to access, to facilities that may be impactful in someone's, health and overall well-being. So again, I mean, I'm looking at Berks Alliance also as a major partner, and I think a critical entity that I think that needs to be at the table as we begin to put together our implementation plan.
Thank you, Jonathan. That's helpful. That's very helpful. Disha, Julie, any closing thoughts?
So I'll add, as Jonathan was saying, MCOs are really starting to reach out to our community-based organizations to really reward them for the work that they've been doing, right? Not new work, but what they've been doing to support our community members. And so my final remarks would be to those organizations, as MCOs are reaching out to you, advocate for your worth, right? Put it down on paper, what you do to support the community every day, and be honest about what your infrastructure challenges are and ask them to help you with that, because the work that you're doing is helping their bottom line. It's helping them to help their members stay healthy, and then helping them to not lose money. And so you have a value, you have a worth in the work that you're doing. And so make sure that when an MCO approaches you to help their members stay safe and healthy, that you put your worth down on paper and you're reimbursed for the great work that you're already doing.
So Jonathan, we have to give everybody your email address so they can send that to you.
I'll be ready.
Julie, anything you want to say?
Not much, just thank you again for the chance to speak with you all today. And we have an open door policy at the RAC program. So if you are interested in engaging in some way or even just receiving information, please don't hesitate to reach out.
And that brings me to what I was going to ask you to do. Could you go back to that slide to tell people exactly how they can be in touch? Because we've had a number of the community-based organizations say that they have begun to do some collaboration or they're very interested in collaborating. A number of our people in the audience are involved with this. The other health system, Penn State St. Joe's, just sent a note saying they're very interested in trying to be involved in this process. And I think there's a lot of, we can try to spread this more broadly to get a lot of I think some of the businesses and some other interests could be very much involved and interested in supporting this activity. So you want to do that again and tell us how to get involved?
Yes, so I just put my email in the chat. Please feel free to copy and paste that and shoot me an email. And then we can also send these slides out to the group if that's okay with you, Dave. I'll make a PDF to send to you to share with the group. And this will have a direct link to our expression of interest form as well as our consumer feedback form. So please feel free to use those and we'll be sure to be in touch.
Great. Well, thank you very much. As I mentioned, we will make sure everybody gets PDF of the slide presentation so they have that and can begin to harass you guys. But it's nice to see that there's a lot of people very interested in this topic and being very interested in how do we work on this. I want to thank our three panelists. I think you did a great job. It was very, very interesting. And I want to thank everybody who showed up to listen to this, and even those of you who are going to be watching this at some later point in time. As I mentioned, we will record the program. We have been recording it. We will send that out to everybody who registered. Feel free to use it if you'd like. We will send the list of the registrants to the 3 panelists so they know who was watching them or who registered for the event, who will be stalking them. I also want to remind people that we have our Spotlight program on Monday at 1 o'clock, where we're going to be focusing on College Town Project by Alvernia and BCTV's relocation downtown. If you use somebody else's way of linking into this, send me your, post your email address so I can have that, so I can send you the video. Somebody said that they stole somebody else's registration. I also want to mention that we'll be doing our next community forum November 18th. It will focus on, Jonathan, you're going to like this, transit-oriented development, or what happens to Reading when we bring the trains back. How do we plan for that? So please consider registering for that program. And thank you again, presenters. I think this was a great program, a really great topic that's really vital to our community. Glad we had a chance to talk about it. So
Thank you for the
all.
invitation.
Thank you all.
Thanks for having us. Thank you.
Sure.